I have no idea how this voting is taking place. Do you want to explain it?
Oh, yeah,
Or no?
We've done the polls before, so
Perfect.
don't worry about that.
Perfect. Okay, so we're starting off with 2 cases, and I want you guys to look at these pictures, and everybody has to vote. Tell me which one is infectious, A or B.
So everybody look at the 2 photos and choose which photo is infectious and which photo is not infectious. So tell us the infectious one, choose it, and give us a vote.
I love watching the votes come in. It's really fun for me.
Yeah.
All right, we have, I think, 10 seconds left to vote. Let's see.
We have 185 participants. Only 120 of them or 110 of them voted. We need everybody to vote. Don't worry about that.
Guys, vote. Vote or you can't complain about your government. So vote.
All right, we're getting there. So I'll stop the vote now.
Okay, excellent.
Everybody voted for A, to be infectious.
So I'm very excited about this, actually. 75% of you chose A as infectious, and only 25 chose B. So this is better than most crowds. We usually get about 50-50. So A is acquired toxoplasmosis, and B is a patient with Behçet's disease that is causing a retinitis, but it's not infectious. And I'll talk about a little bit more about this shortly. So our next one, our next case, let's see. I'd like people to vote again now. Which is infectious, A or B? We have 30 seconds again, and I want everybody to vote.
All right.
This one might be a little bit tougher. Let's see. You guys are doing a good job voting. This is higher turnout that we get in the United States elections. We have 70% turnout so far. That's pretty good.
Okay, so
you want to stop it?
I'm going to stop the poll, and we got 70%.
All right. So here we have it flipped. We have 25% for A and 75% for B. So I'm going to tell you that I cheated here on A. A is actually a patient with toxoplasmosis, and you can see that there's arteriolar and venular sheathing, but the toxo lesion isn't in the picture. When you see a patient in your clinic, they don't come with a circle and arrow around the picture or around the lesion of interest. And the patient in A was actually referred to me for immunosuppression for retinal vasculitis. And there was only a small peripheral toxo lesion. B, that looks very much like frosted branch angiitis from herpetic disease, is actually another patient with Behçet's disease. So the point here is only that you can't tell necessarily easily by looking at a picture or even at the patient if the disease is infectious or not. So here's our third one, same question, which is infectious, A or B?
Now we're getting the split vote.
We're getting close to 50-50 here. This is really interesting. That's what makes this fun. Everybody has to vote. Only 50% of you have voted. Come on, get up and vote for me. We'll stop the vote when we get to 60%. We're going to be here a long time. Let's see. All right. We're at 61% voting. So I think we've got 43% have chosen A and 50% have chosen B. And again, the point here, and I like that it's around 50-50, is you can't tell just by looking at a picture or just by looking at a patient if the disease is infectious. In fact, A is multifocal sarcoid retinal granulomas, and B is a case of herpes zoster retinitis. And my point here isn't to trick people, but just to get home the point that you always need to think of infectious disease. And no matter how good a clinician you are, you can't necessarily tell just by looking at the patient. So our next case, same question. Oh, let's see if I can make my computer wake up. Which of these two is infectious? Again, A and B, 2 choices. I'm sparing you by not singing while the votes come in. At the Academy, there's music.
Okay, now we have 245 participants. for those of you who had just came in, we are now displaying two pictures, and you should choose one of them as infectious and vote in the poll.
All right. So for this one, we have 75% voting for A and 25% voting for B, which makes me happy that I chose good pictures. Actually, in this case, B is a patient with toxoplasmosis. This is acquired toxoretinochoroiditis. And A, this is an area of retinitis with vitritis and vasculitis, but this is Behçet's disease again. So the point here is that there are conditions that are very easy to confuse with infectious retinitis, and retinitis, retinal vasculitis should make one think of infection, but we can certainly also see non-infectious causes like Behçet's disease. And our next one, which is infectious, A and B, A or B. I promise only one is infectious. I like getting to see the votes coming in live. It's pretty fun. Okay, so you guys are really good. We have 70% choosing A, and A is actually a very immunosuppressed patient, and this is CMV retinitis. There's also a vasculopathy, and B here is again Behçet's disease. You can see there's areas of retinitis, hemorrhage, and retinal vasculitis of Behçet's, and this is CMV retinitis. I'm almost done with these cases. And then here we have two arteriolar occlusions. Tell me which one of these is infectious.
Okay, I'm going to wait. I'm not going to launch the poll now. I'll give them like 10 seconds because they're saying that the poll sometimes covers the pictures.
Oh, that's not
now. I'm going to launch the poll.
Okay. Oh, I love this. It's so close to 50-50. It makes me so happy.
Yes, you chose your pictures wisely.
Oh, I'm really excited. We're like neck and neck, like two horses just coming to the finish line at 51 and 49. All right.
We still have like 90 people didn't vote. Come on.
Okay, I'll let you guys vote. I'm an impatient person.
They don't want to vote. Okay, we're done. Nobody's voting anymore, so.
Okay, so we have 50-50. So A is again a patient with Behçet's disease, and this is a young kid with toxoplasmosis. And you can see there's a little lesion over here. This is actually a child who presented to our pediatric hospital with eye pain, KP, AC cells, a very high intraocular pressure, but then someone looked in the back and saw the arteriolar occlusion. They forgot about the KP and the AC cells and the high pressure. He was admitted to the hospital and had this extraordinary workup for hypercoagulable state, when in fact this was an arteriolar occlusion secondary to a toxoplasma lesion. So I'm going to leave this quiz now and try to go through the most common causes of infectious retinitis, in most cases basing this on cases because that's what we do. We are ophthalmologists and that's what we do. So our first case starts ages ago in 2007. This gentleman was 68 years old at the time, and he had floaters and decreased vision in his right eye. He had been diagnosed with primary, at the time it was called intraocular lymphoma, so primary intraocular lymphoma, and referred to me. In fact, he had decreased vision on that side. The left eye was completely normal, and what he had did not look like primary intraocular lymphoma. He had granulomatous KP, anterior chamber cells, vitreous cells, cystoid macular edema in his right eye, and a few choroidal granulomas, and no retinitis. So I think the diagnosis of primary vitreoretinal lymphoma had been made really only based on his age. So for me, the most likely thing was sarcoidosis. Whenever you think of, oh, I have somebody who raised their hand. Let's see. How do you want me to handle that? Are you going to handle that well?
Well, let's put the questions after, like when you're. I don't think
Okay.
if we take questions in the middle, it's going to be very difficult.
Okay, so I'll take breaks. So whenever we think of sarcoidosis, we always have to think of tuberculosis. Those diseases can present in an extraordinary similar fashion in the eye and in the lungs. We think of syphilis in every patient with uveitis. Every country in the world has syphilis. And I thought that intraocular lymphoma was very unlikely. He had a workup. The angiotensin converting enzyme was normal. The lysozyme was elevated. Syphilis testing was non-reactive. PPD was negative. And his chest x-ray had a lung nodule. He didn't have hyaluroadenopathy or the interstitial pattern that we typically see with sarcoidosis. So we sent him for a lung biopsy, as this certainly could have been lung cancer with unrelated uveitis. And the biopsy showed non-caseating granulomas consistent with sarcoidosis. So we have panuveitis in one eye secondary to sarcoidosis. We gave him a short course of topical steroids. We did a posterior subtenon triamcinolone injection. His inflammation gets better. His cystoid macular edema goes away. His vision comes back to 20/20, and he follows up with me for about a year. But he lives really far from Chicago, so he's followed elsewhere for 6 years after that. So in 2013, he has floaters again in his right eye. So he goes to see a retina specialist who says, well, you've had sarcoid uveitis before, you have sarcoid uveitis again. Let's put in a steroid implant. Let's do an Ozurdex, a dexamethasone implant. And he was prepped on the table to get the injection. This is a man who has 6 sons, and one of his sons says, you know, why don't we, before we do an injection, why don't we see Goldstein again and see what happens? So he comes back to see me, has not yet had his Ozurdex. His vision is 20/40. The left eye is again perfectly normal. He again has KP. At this time, they're greasy KP, but they're almost confluent over the entire cornea. He has 2+ anterior chamber cells. He has vitreous cells and vitreous haze. And here's the fundus of his right eye. You can see that this looks nothing like sarcoid uveitis. We see a large patch of retinitis that is quite flat. There's one satellite lesion, and you can see that it looks like there's central clearing. So to me, this looks most like acute retinal necrosis. Given his age, this is most likely herpes zoster. This can also be toxoplasmosis, but with how flat it was in the central clearing, I thought that herpes zoster was most likely. So we did an anterior chamber tap for varicella zoster, herpes simplex, and CMV. And in 2013, it wasn't so easy to get toxo-PCR on aqueous, so we didn't do that. And we started him on oral acyclovir 2 milligrams 3 times a day and topical prednisolone acetate. Workup, the FTA was negative and aqueous PCR was positive for zoster. So we have a patient who's had sarcoid uveitis in one eye, comes back with a recurrence, and despite the fact that he has known sarcoid, he comes back with infectious retinitis. So here he is 8 days after treatment with Valtrex 2 grams 3 times a day. He's got remarkable clearing. I didn't give him any oral steroids because he had very little inflammatory response. And here he is after 2.5 months. You can see the lesion has completely recovered. So I follow him for a long time, and then he comes back in 2016 and he has new floaters in the left eye. He has no KP though, and no AC cells. So my question when I see him is this sarcoid? Is this herpes? What's going on? We do a good dilated exam, and actually what you can see here is he just has a retinal tear. He had a PVD, a retinal tear, and a bit of vitreous hemorrhage. He has since come back actually with his right eye with acute retinal necrosis again. So the teaching points for this case are remember infectious causes of uveitis in every patient. Even a patient with known non-infectious disease may get infectious retinitis. And we all learn in medical school Occam's razor, which is that we have to make everything into one unified diagnosis. But the flip side of that is Hickham's dictum, which is a patient can have as many diseases as he pleases. So our next patient is referred with a diagnosis of anterior uveitis and optic neuritis. So this is a 30-year-old woman who was pregnant at the time, and she had pain, redness, and decreased vision in her left eye. So the optometrist who saw her diagnosed her with iritis and puts her on prednisolone acetate every hour, but she doesn't get any better on this. She then develops floaters and decreased vision in her right eye. So then she's diagnosed with optic neuritis. The optometrist calls a neurologist who starts her on oral prednisone for a presumed diagnosis of optic neuritis. and her vision continues to decrease. So she self-refers to the uveitis service. Her visual acuity was 20/20 in the right eye, or 6/6 in the right eye, and hand motion in the left. And she had anterior chamber cells in both eyes, as well as very extensive, greasy, large chorotic precipitates in her left eye. So here's the fundus exam of her right eye. She has vitreous cells. The peripheral retina is normal. The only thing we see on exam of the right eye is the very swollen optic nerve, and you can see that there are cotton wool spots here. But very importantly, the eye that has been treated for 3 weeks for anterior uveitis has extensive retinal necrosis, 360 degrees. So this is a diagnosis of necrotizing herpetic retinitis in both eyes. She was treated at the time very aggressively with systemic and multiple intravitreal injections for acute retinal necrosis. Her right eye recovers, but she has a visual field defect, and her left eye has light perception vision despite aggressive therapy. So in this case, the prognosis was dramatically worsened both by the delayed diagnosis, but then by starting oral steroids without antiviral therapy because the diagnosis was delayed. So again, always think of infectious disease, and every patient with uveitis gets a dilated fundus exam. In this case, she was just diagnosed with anterior uveitis, but you can't diagnose anterior uveitis without a retina exam. Anterior uveitis does not mean there's cells and flare in the anterior chamber. Anterior uveitis means there's cells or flare in the anterior chamber, but you've looked at the back and the retina is okay. In this case, it was a panuveitis because of infection. So not all uveitis is treated with steroids, and we always need to consider infectious causes. And I always want you to consider herpes, toxoplasmosis, and syphilis. So in the case of herpetic retinitis, we tend to somewhat arbitrarily divide necrotizing herpetic retinitis into acute retinal necrosis and progressive outer retinal necrosis. But these are the same organism. The difference is the host immune response. The most common organism is herpes zoster, followed by herpes simplex and CMV. CMV is a very rare cause. Herpes simplex is a more common cause in teenagers and younger patients. So it usually begins in one eye, but it becomes bilateral very frequently. And one of the main reasons to treat systemically is to prevent involvement of the contralateral eye. So I often have residents say to me, well, can't I just treat this ARN patient with intravitreal ganciclovir foscarnet? And we often do that, but we do it in addition to systemic therapy to protect the other eye. And the other eye is usually involved within 6 weeks, which is where that minimum treatment for 6 weeks systemically comes from, but it's been reported up to 30 years later. And we see this in every age, but there are 2 peaks, one at around age 20 and one at around age 50. And I've said that we see this in immunocompetent patients or patients who are relatively immunocompetent, because we often find that there are immune dysregulations in patients with ARN. We see this more frequently in pregnant patients, in older patients who are immune suppressed by virtue of their age. We see it more commonly in very young patients. We see it more common in patients with atopy and other kinds of immune dysregulation. So here's a classic picture of acute retinal necrosis. The view is very hazy. We can often get a lot of vitritis. So if you look in the eye and there's a lot of vitritis and something white in the peripheral retina, number 1 on your differential should be acute retinal necrosis. This can also be Behçet's disease, but it is important that we always think of infection. If you think this is Behçet's disease and put the patient on immunosuppression rather than treating ARN, and it turns out to be herpetic, you have blinded the patient. Whereas if you think that it's ARN, but it turns out to be non-infectious, all you've done is waste a few days giving antivirals. So it is really important to always think of infection first. And this is the patient that I showed you who was treated with oral corticosteroids. And this is the very classic areas of patches of retinitis in the periphery. And you can see a little bit of clearing here actually along the veins and some hemorrhage. But this tends to be very flat. It doesn't tend to have the substance to it that toxoplasmosis has. So the patients can present with just decreased vision or floaters, but pain and photophobia are very common. And in fact, a lot of patients with infectious retinitis come to the attention of us first because of pain, redness, and photophobia. We can see anterior chamber cells and flare. We can see KP. They can be small and stellate, but more commonly they are large in mutton fat. We can see significant vitritis. Importantly, acute retinal necrosis may also present as scleritis. So every scleritis patient needs a good dilated fundus exam. We can also see an optic neuritis picture, as we saw in the patient that I just showed you. So again, every patient with uveitis and scleritis needs a dilated fundus exam. It sounds so obvious, but I can't tell you how many times this doesn't happen. So what happens to these patients? Well, they do worse if you miss the diagnosis. So they do worse as the patients that I just showed you when there's a delay in diagnosis and when the initial therapy is with corticosteroids. Also, increasing age portends a worse prognosis, increasing relative immunosuppression, and if the patient presents with more retinitis to begin with, they obviously do worse than a patient with a small patch of retinitis, like the first patient that I showed you. Despite therapy, retinal detachment is very frequent. It tends to occur during the resolution phases. And that's one of the reasons that we use corticosteroids in patients with a lot of vitritis, because we can get vitreous bands and vitreous traction. The infected retina, as it resolves, is very thin and necrotic and very susceptible to any amount of traction. So we do want to prevent spread of necrosis in the retina and reduce the amount of traction. So this is a clinical diagnosis, but if you need help making the diagnosis, serology is not helpful. Most of the world has titers to herpes zoster, and a lot have to herpes simplex as well. So I really hate seeing patients where a diagnosis is made on serology. So it's a clinical diagnosis, or we can do Goldman-Whitver coefficient, looking at antibody production in the aqueous compared to serum. We can't do that in the United States. There are no commercial labs that will run antibody testing on small aliquots. We initially used to do PCR on vitreous specimens, but we've known for a very long time, almost 20 years, that PCR on the aqueous has very high yield. I actually almost never do a vitreous tap for PCR. Aqueous tap is so easy, the risks are so low, and the yield is really high. So we do PCR on aqueous. This is a test that's done very easily as a send out from a lot of places. So how do we treat? When I started, we treated patients with IV acyclovir. I rarely do that unless I have a patient who is really non-compliant or homeless that I need to take care of keeping in the hospital. The dose, if you are going to do IV induction, is 5 to 10 milligrams per kilogram per dose, and it's dosed every 8 hours. I've put the milligram per meter squared dose in because sometimes that shows up on board exams. I have absolutely no idea how to calculate milligrams per meter squared. There's some kind of little dialy thing that we used to carry in our pockets as residents. I have no idea. We usually will treat now with induction doses of oral agents. We know that oral valacyclovir or famciclovir reach serum levels as high as IV therapy. So I tend to use Valtrex 2 grams TID as induction dose for acute retinal necrosis. And then patients, people always say, well, how long do you do the induction? The classic answer is 2 weeks, but I'll actually keep induction doses going until I have some control of retinitis. It doesn't make sense to me to start decreasing therapy if I don't have control of the disease. We very often use concomitant intravitreal therapy. So I've said that I don't use monotherapy with intravitreal agents because I want to protect the contralateral eye. So we can do intravitreal ganciclovir, and the most common dose is 2,000 micrograms and 0.05 cc. But ganciclovir has a very broad safe dose range. You can use anywhere from 200 micrograms to 7,000 micrograms. Foscarnet we draw straight from the IV bag, so the concentration is 2,400 micrograms and 0.1. So that's the highest concentration that we use. And I will offer this to anybody with sight-threatening disease, anybody whom I'm not getting good control of with systemic therapy, or anybody developing new lesions or contralateral disease while on systemic therapy. In terms of treatment, the classic teaching has always been that we treat for 6 weeks. I've never treated anyone for that short a time. The shortest I've done, I think, is 3 months in patients with normal immunity. But in patients who have had recurrent disease, or who are immunocompromised, I will continue treatment indefinitely. So I have a patient who is on Humira for his inflammatory bowel disease, had ARN. He will stay on maintenance doses of therapy forever, monitoring renal function. I have a patient who's had recurrences twice in each eye. He is going to stay on therapy indefinitely. We definitely get better results of treatment with, get better control of retinitis with treatment, but unfortunately it does not decrease the incidence of retinal detachment. So what are additional treatments we could do? When I trained, we were taught to use laser retinopexy posterior to the necrotic retina. I don't do that anymore. I think that you're using up retinal real estate. So somebody with a very small patch of retinitis really has a low chance of developing retinal detachment. And somebody with extensive retinitis heading towards the posterior pole, I think you're just using up real estate by doing laser. So I don't do this. We add systemic corticosteroids if there's a lot of inflammatory response. You can do 0.5 to 1 milligram per kilogram every day or every other day, but you want to make sure that you've started antiviral therapy first. And please never do monotherapy with corticosteroids. This is a patient of mine from Eastern Europe who was treated at home about 20 years earlier for something in his eye. He didn't know what, with IV something in the hospital, and he recovered. And then he moved to Chicago and had inflammation in the second eye and was treated with a local steroid injection. And this is acute retinal necrosis involving every micron of the retina from the disc to the aura. We were not able to save this eye despite aggressive systemic therapy and intravitreal therapy, and the eye became physical. So really, if you don't know what you're treating with uveitis, please do not put an injection of steroids in or around the eye. So progressive autoretinal necrosis, and I really hate the name porn, I don't know what somebody was thinking, is the same disease as ARN, but in a different host. So the host is immunocompromised, so there's obviously less inflammatory reaction. So we don't see the AC reaction, we don't see a lot of vasculitis, we don't see a lot of vitritis, but again, it's the same organism. You can just try to imagine what the response would be to that organism in somebody with a poor immune system. So this is a patient who presented with the classic picture of progressive outer retinal necrosis. You can see that there's these patches of retinitis that extend all the way to the optic nerve, and they become more confluent in the periphery, but you can see that we don't see any vitreous haze here, and we see very little vasculitis. And I put this slide in just to remember me, if I could speak English, that would be good, right? To remind me to tell you that this really is same organism, different host. So this is a woman whom I saw at this point 20 years ago. She had chronic lymphocytic leukemia and had recently had a recurrence and was treated with Cytoxan. She presented with the picture of progressive outer retinal necrosis with inflammation and necrosis all the way to the posterior pole. As we stopped her Cytoxan and tapered her steroids and treated her with antivirals, she then developed a more aggressive immune response, developed vitritis, and developed vasculitis. So her disease didn't change from ARN to porn. It was necrotizing herpetic retinitis with varicella zoster, and what changed was the host immune response. So I think I'm going to leave herpes now. Do you want to pause for questions about herpes or do questions at the end?
Yes, we have 4 questions only in the chat, okay. Which is why is ARN exclusively at the peripheral retina? And if you get a tear and you're developing retinal detachment, how do you treat it? Do you do laser? And do you use aspirin for patients with ARN? And someone was asking about the frequency of intravenous treatment and when to stop it.
Okay, a lot of questions. So it's not always peripheral retina. It's preferentially peripheral retina when it starts, and it's often multifocal, but we do see patients where we really see early posterior involvement. So that the answer is it's not exclusively peripheral. You can certainly laser around a tear if there's healthy retina around. Very often these patients go to vitrectomy, and very often if there's extensive necrotic retina, 360 degrees, vitrectomy with oil. I don't use aspirin. I was not convinced by the data initially, so I really don't, especially if we're considering using oral steroids. I think that starting any non-steroidal anti-inflammatory, including aspirin, with prednisone really does increase your risk of GI side effects and GI bleeds. What was the other question?
The frequency of intravenous treatment and when to stop it?
So so the intravenous treatment, if you give it, it's given every 8 hours as induction, and then you can decrease it for maintenance. It's much easier if you do maintenance with oral therapy. If you're in a country that has acyclovir or famciclovir, oral acyclovir has pretty bad absorption. You can do maintenance with oral acyclovir, but it's really not as good as acyclovir.
Okay, now we can move.
Okay. Any other questions about herpes before I move on?
No, we're good. We're good.
How are we doing for time? We okay?
We're absolutely fine. Don't worry. Everybody's waiting is going to be like staying there with you whatever time you take.
Okay, awesome. I got nothing to do here. I don't have patients till tomorrow. All right, so this is a patient. She's a 53-year-old woman, and she's referred for intermediate uveitis in her right eye that's not responding to 60 milligrams of prednisone. And she's actually not referred by the retina specialist. I'm sorry, I keep picking on retina specialists because he was planning to do an Ozurdex. But her husband is a cardiologist, and he said, I can't really understand why it's 60 milligrams of prednisone isn't touching her. We don't have a diagnosis, why we're gonna do a steroid implant. So he Googled and found me. So she comes for a second opinion. She's got 20/60 vision in the right eye, 20/20 in the left eye, and the left eye is completely unremarkable. The right eye slit lamp exam is unremarkable, except for vitreous cells and strands. And I took this picture, this is in retroillumination, and you can see these strands and clumps of cells in the vitreous. So we're looking at somebody with what looks like intermediate uveitis not responding to prednisone. But when we look at the retina, superiorly, this is at 12 o'clock, there is a giant lesion in the retina that was somehow either missed or ignored. So this actually has quite a thickness to it with a thick border at the end. So when we look at something like this, we definitely think of infection. This could be acute retinal necrosis, but the time course was really long, and this lesion really was quite thick. So I decided that this was most likely toxoplasmosis and what we used to call massive toxogranuloma. And we treated her with oral antibiotics only, and here she is after therapy for toxoplasmosis. And I think the before and after picture shows you really nicely that this really was elevated and exuberant and active. And this is the atrophic lesion that we have now. So again, when you see something in the retina, when you see something in the vitreous, you need a really good fundus exam. And if a patient isn't responding to oral steroids, an Ozurdex may not be the answer. So my summary here, like I said, if the disease worsens on oral steroids, reconsider your diagnosis, and not all uveitis is treated with steroids. So this is another patient referred for intermediate uveitis. He's a 71-year-old male who's had floaters and blurred vision in his left eye for 3 weeks. He's got systemic myelofibrosis that he's had for 14 years, and he's now on immunosuppression that is really at this point palliative, so he can breathe until he dies. So he's on a JAK inhibitor and is quite immunosuppressed. He is seen by an optometrist, diagnosed with iritis, and started on topical steroids. He doesn't improve, so he's seen by an ophthalmologist, diagnosed with intermediate uveitis, and started on oral prednisone 20 milligrams a day for a week. So I see him after he's been on oral prednisone for a week. So what do we think of when we see new intermediate uveitis in a patient who is very immunosuppressed because of age, because of systemic disease, and because of being on a profound immunosuppressive agent? This is very unlikely that this guy has new sarcoid uveitis or parsplenitis. So what is our differential? Infection, 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 and maybe this is also a malignancy. So the right eye is normal except for vasculopathy. The left eye has decreased vision. His pressure is normal. He has AC and vitreous cells. Importantly, he has posterior vitreous precipitates. And what I mean by that is that there's been a posterior vitreous detachment, and on the back of the PVD, there are these little deposits that look like KP on the back of a PVD, and he has vitreous haze. So this is the photograph just showing you the amount of vitreous haze. And here we can see an area of retinitis inferiorly. It's cleared centrally, and it's got this brush fire appearance. And here's another photo showing you the vitreous haze. It's cleared here and has a brush fire appearance. So this really looks like necrotizing herpetic retinitis with zoster or simplex or CMV. But the posterior vitreous precipitates, we can also see much more commonly, in fact, in toxoplasmosis. So the question is this ARN or is this toxoplasmosis? So what do we do about it? So we do an AC tap for PCR for herpes viruses and toxoplasmosis, but I did an intravitreal injection of ganciclovir and foscarnet because if this is toxoplasmosis, it won't blind him this quickly, but if he is immunosuppressed with ARN, this can blind him very quickly. And the PCR came back negative for all the herpes viruses, but it was positive for toxoplasmosis. So what kind of points can we take home from this, or keep at home, since we're mostly at home now anyways, is that, again, you need to look at the retina in all uveitis patients. Immunosuppressed patients can get non-infectious disease, but infectious disease is much more likely. Posterior vitreous precipitates, not pathognomonic for toxoplasmosis, but much more common in toxo. And we learned this during the AIDS epidemic, that toxoplasmosis can look exactly like CMV retinitis or ARN in immunosuppressed patients. There were a lot of patients back in the AIDS day who we thought had CMV retinitis who didn't respond, and on vitrectomy were found to have toxoplasmosis. So always think of infectious causes, and again, not all uveitis is treated with steroids. So here's another patient. This one's referred with anterior uveitis. It's a 64-year-old male, and this time I'm not picking on the retina service because he's referred by a glaucoma practice. Because he has anterior uveitis, he's been on topical pred acetate for 3 weeks every hour and is not getting any better. So vision is 20/20 in each eye. His slit lamp exam is normal in the left. Fundus exam is normal in the left. The right eye has 2+ anterior chamber cells, and he has granulomatous keratotic precipitates. And the pressure is very high on this eye. So the question is this anterior uveitis? And we look in the retina, and clearly this is not anterior uveitis. As I've said, we only call something anterior uveitis if the retina is normal. So this is a patient with retinitis, vitritis, and anterior chamber inflammation. This is a panuveitis. So we see a patch of retinitis here. It's a pretty small patch, but it looked a little bit elevated to me. There was a little bit of vasculitis. So I decided that this was toxoplasmosis. I didn't do an AC tap here, and I started him on azithromycin. He doesn't get any better, so I do intravitreal clindamycin. So here he is when he presents to me on March 10th, and here he is on March 31st. He's on azithromycin, and he's had 1 intravitreal clindamycin injection, and this lesion is 3 times larger. So I'm clearly not doing a good job. So the question is, why not? So what do? I do an AC tap, because maybe I was wrong. If any of my fellows hear this, don't admit it, but I can be wrong. So we do an AC tap to see, is this really toxoplasmosis, or maybe this is atypical acute retinal necrosis. In fact, the PCR was positive for toxoplasmosis and negative for herpes viruses, so we changed the antibiotic and his retinitis gets better. So number 1, you need to look at the retina in everybody with anterior uveitis. And number 2, if your disease is not responding as you expect, reconsider your diagnosis and then reevaluate your therapy. So just like the patient that was referred who was supposed to get an Ozurdex when oral prednisone fails, you need to stop before you go to the stage of Ozurdex. If the disease isn't responding the way you think, reevaluate the diagnosis and then reevaluate your treatment. And toxoplasmosis is a really common cause of posterior uveitis. So in immunocompetent patients in the developed world, it is 20 to 30% of all posterior uveitis. So that's not 20 or 30% of infectious uveitis. It's 20 to 30% of all posterior uveitis in people with normal immune system is toxoplasmosis. So everybody is going to see toxoplasmosis. Importantly, while patients can present with decreased vision and floaters, they can also present with pain, redness, and photophobia. So this is a patient of mine with toxoplasmosis, and you can see that there are granulomatous KP. Very often, there's also a high intraocular pressure. Toxoplasmosis, like ARN, is one of the causes of high IOP with acute inflammation. It is the commonest cause of retinitis in people in the United States. In a survey in California, there were 2.46 active cases per 100,000 population. Russell Reed did a study in Alabama, and just over 0.5% of the population has inactive retinal scars. And in my series, 5.6% of all pediatric uveitis, that's not just posterior, but all pediatric uveitis, was toxoplasmosis. So how do we make the diagnosis, and how common is serology? Well, the serology is really interesting. Almost 1/4 of US adults have positive IgG for toxoplasmosis. It is almost exactly the same in Egypt. It's a little higher in pregnant women, and there's a nice study showing that it's 45% in type 1 diabetics. I was looking up the serologies on animals in Egypt as well, because the question is, how do so many people get positive toxoplasmosis when we don't eat pork? So interestingly, over half the sheep in Egypt have positive serology for toxoplasmosis, and 97% of feral cats have toxoplasmosis. So there's the answer to where the toxo comes from. 30% of the adult population in Doha has serology. Again, 1/3 of adults in Saudi, including pregnant women, have serology for toxoplasmosis. So that is very similar to the United States. Starts to get very high in other countries. 2/3 of the population in France has serology. They eat a lot of raw meat. And in southern Brazil, where they eat a lot of raw pork, the percentage of serology is almost 100%. So we decrease it by not eating pork, but we don't get it to 0. So I won't talk about the life cycle, I promise, except to tell you that there's 2 forms of the organism, the tachyzoite, which is pretty easy to treat, but the bradyzoite, which insists and can lie dormant in the retina for years. And this is why it's very hard to prevent toxo recurrences, because most of our treatments aren't effectively treating the bradyzoite. So in terms of the life cycle, I mentioned cats because the cat is the definitive host, and when they poop, they secrete millions of oocysts, and these can remain viable in soil for 1 year. For anybody who wonders why I live in a cold and horrible climate, this is Chicago in the winter. This is the Chicago theater and the nasty snow we need to walk through. Well, at least when we get to minus 20 degrees centigrade, we kill the oocysts, but you have to get to 66 degrees centigrade to kill it when you're looking at heat. So we have some advantage living in horrible cold climates. Not a lot of advantages, but some. So where does human infection come from? It is most common in pork. After that is mutton, and then beef. The United States has no toxoplasmosis in commercial beef cattle, but we see it in people who eat pork, and we also see it in hunters who hunt wild deer, and they get a lot of toxoplasmosis. But even if you're a vegetarian, you can't be too proud of yourself, because we can actually get infection from vegetables, from contaminated water. As I said, the cat is the definitive host, which is why we don't want pregnant women handling cat feces. Water filtration in most cities removes most particles, but if you drink well water or stream water, you're at risk. We're also at risk from organ transplantation, transplacentally, and even inhalation around cats. I'm a dog person, not a cat person. So toxoplasmosis can be congenital or acquired, and the old literature used to say that it was mostly congenital. In fact, that is not correct. The majority of toxoplasmosis is acquired postnatally, and we know that from really good studies on high endemic areas like in southern Brazil, but also endemic studies in other countries. So this is a classic picture of congenital toxoplasmosis. This was a patient of mine who was in her teens. She was diagnosed with toxoplasmosis at birth with positive torch titers. And you can see these large macular scars that used to be described as macular coloboma. And you can see she's had 1 recurrence here and a lesion here. The only thing that looks like this, other than toxoplasmosis, is North Carolina macular dystrophy. This is another patient with congenital toxoplasmosis with a large macular scar. So these are a few patients with newly acquired toxoplasmosis. This is the first patient I showed you in the quiz. This is a patient actually from Brazil, but had his first episode of toxoplasmosis with me in Chicago. You can see the dense area of retinitis and extensive vitritis. And these are 2 other patients with acquired toxoplasmosis. You can see that the lesion is slightly elevated here. It's more obvious. There's surrounding retinal infiltrate. And here you can actually see these little dots here, these are actually posterior vitreous precipitates. The vitreous is starting to come off and we're getting little deposits. You can also see that there's areas of vasculitis. We can see vasculitis near the area of retinitis, but we can also see in the second patient I showed you, diffuse vasculitis everywhere. So recurrent toxoplasmosis typically occurs at the edge of an old scar. So here we see a scar and then the recurrence of toxo. Here's multiple scars with a recurrence. This is really a classic clinical picture. I don't think you need to do any testing when you see this. When you see a patient that looks like this is toxoplasmosis. And again, you can't tell by looking at this patient if this lesion here was acquired pre or postnatally. So this is a patient that I showed you before with congenital toxoplasmosis, and here she is having a small recurrence. Here's another patient. This is a known patient with congenital toxoplasmosis, and here is a new active lesion. You can see the lesion looks a little elevated. There's surrounding retinal edema. More cases with recurrence, just to show you, this is a pathognomonic picture. Old scar, white retinitis, and there's some vasculitis here, there's some vasculitis here, some vasculitis here. We can get arteritis or phlebitis. Here's another toxo lesion, and I'm going to just keep showing pictures because every one of you will see toxoplasmosis in your clinic, and these are really pathognomonic clinical pictures. So here is the reactivation of toxoplasmosis, and this patient actually has subretinal fluid here. I told you about the vitreous precipitates. These are actually two different patients with vitreous precipitates with a PVD where we can see the precipitates right behind the lens, but here's a patient where the vitreous precipitates are sitting right on the retina. You can see this with herpetic retinitis, but it is important to think about this in toxoplasmosis. Again, you can get the vasculitis being arteriolar or venular. Most non-infectious vasculitis is venular. So Behçet's disease is an exception where we can see vasculitis along the arteries and the veins, but most cases with sarcoid, for example, it is only veins. So here you can see the arterioles have a lot of sheathing. Here's the arterioles, there's the old lesion, here's the active lesion. Here's the patient I showed you before with vasculitis around arteries and veins, and the lesion of toxoplasmosis is up there somewhere else, not in the screen. Again, I'm just going to keep showing you pictures. This is an acquired toxoplasmosis. There's retinal edema and subretinal fluid here, and remote vasculitis. And there's the kid that I showed you with a branch retinal artery occlusion from toxoplasmosis. This is the patient I showed you, toxoplasmosis in the immunocompromised host. So how do we diagnose this? This is mostly a clinical diagnosis. We don't make a diagnosis based on serology. I can't tell you how many patients I have sent to me who clearly had birdshot or Behçet's or lupus or something else, but someone does serology, they have positive IgG, so they're diagnosed with toxo. As I've said, a quarter of the population of Egypt, a quarter of the population of Saudi Arabia, a quarter of the population of the United States has toxoserology. Once you get to France, it's 2/3 of the population. A negative serology also doesn't rule it out. And this, I think, is a mistake that is made very often. Somebody will see a patient with recurrent toxoplasmosis, but the serology is negative. So I would expect positive serology in acquired toxoplasmosis if it was recently acquired. But if somebody is 60 years old, acquired the toxoplasmosis when they're 5 years old, and then they get a recurrence, it is not surprising that the IgG in serum is not still measurable 50 years later. IgG does not stay around forever. And we have all seen cases. I have patients with PCR positive aqueous and negative serology of toxoplasmosis. This was a case that was published with negative serum IgG, positive IgG in the vitreous, and actually identified bradyzoites and tachyzoites in the vitreous. So negative serology doesn't rule out the diagnosis. Positive serology doesn't make the diagnosis. I use aqueous PCR. Goldman-Whitmer is probably better, but again, I can't do that in the United States. So how do we treat these patients? There is no data that any one treatment for toxo is better than any other treatment. My mentor, Howard Tesler, had described quadruple therapy. This is pyrimethamine plus sulfadiazine plus clindamycin and then starting prednisone. If you use pyrimethamine, please remember that patients can get bone marrow suppression and you should use folinic acid with it. I actually urge anybody not to use pyrimethamine if they don't have to anymore, just because Daraprim's price went up about 6 billion times when it was bought over by a different company, and I think that that's horrifying. You can use sulfadiazine. Patients need to be told about avoiding sunlight and about Stevens-Johnson, and clindamycin, we need to remember pseudomembranous colitis. And the treatment is supposed to be at least 6 weeks. I've never treated someone for that short a time either. We can also do monotherapy, azithromycin. I use a lot of azithromycin. Azithromycin is in the news now because it's been used with chloroquine, hydroxychloroquine for the coronavirus. We need to remember that patients treated with azithromycin are at increased risk of prolonged QT interval, and they may die from cardiac complications. We can use atovaquone, which is Mepron. I don't use a lot of it. It's used 4 times a day, which is hard. And the liquid apparently looks and smells and maybe tastes like urine. So I don't use that as my first line. The important thing is that these 2 agents, we were really excited when they came out. They're cysticidal in vitro, but at least with only 3 months of therapy, they're not cysticidal in vivo, because with 3 months of therapy, we do not decrease recurrences. I showed you one patient who didn't respond to azithromycin, so I wanted to show you one who did. So here's a patient with acquired toxoplasmosis, and here he is a couple of weeks later with monotherapy with azithromycin. We can also use monotherapy with Bactrim, that's trimethoprim sulfamethoxazole. That dose for that is 1 double strength twice a day. And we can use minocycline, which is actually what I used for that patient with the large granuloma. We can do intravitreal therapy, clindamycin plus dexamethasone. That's not a panacea, but it is helpful. You may need 2 to 5 injections. I add that in patients who have very difficult to treat disease. So the first patient I showed you, the one from Brazil, had really difficult to treat disease. So I added intravitreal clinda and dex to his systemic therapy. We also offer that in pregnant patients with recurrent toxoplasmosis or in patients who don't tolerate systemic therapy. But please don't use intravitreal triamcinolone. This is a picture shared with me from my colleague Emilio Dodds in Buenos Aires. This was a patient who was treated with intravitreal clindamycin, but instead of dex, they used triamcinolone, and he has this huge area of retinitis that actually extends through 2/3 of the retina. What about secondary prophylaxis? There was data from Brazil, a 1-year study. Patients with active toxo were treated first with trimethoprim sulfamethoxazole for 45 days, and then they were randomized to receive either Bactrim DS 3 times a week for 12 months or to placebo. And by 1 year in the treatment group, there were no recurrences, and almost 13% of the placebo group did have recurrences. So I use secondary prophylaxis in patients with sight-threatening disease, so anything threatening the fovea or the nerve, monocular patients, and anybody who's had frequent recurrences. And we use Bactrim double strength 3 times a week. In terms of pregnancy, at least in theory, we only transmit newly acquired disease to the fetus. So in terms of recurrent disease, we can either observe, we can treat locally, we can treat systemically, but please talk to obstetrics before you do that. In terms of treatment options, we can use clinda and azithromycin in pregnancy. We've put in spiramycin because that shows up on our board exams all the time. I don't know why, because spiramycin might be safe in pregnancy, but it's never been available in my country ever. But it still shows up on US boards. We don't use pyrimethamine in pregnant or lactating women. It is teratogenic and causes bone marrow toxicity. So recurrent disease, I still call the obstetrician, but I can treat the patient. But if a patient has newly acquired disease, they need to be referred to high-risk obstetrics. They do amniocentesis and decide how or if the fetus will be treated. So I am not competent to treat the fetus that may be infected. I can only treat the pregnant mother. Any questions now on toxoplasmosis before I go on?
Okay, let me see. In the chat, is there presence of retinal vasculitis in toxo? Is the presence of vasculitis in toxo an indication for steroid?
So that's a great question. And it probably is. We can see it's not common, but we can see arteriolar occlusions. So I do use steroids in anybody with extensive vasculitis. Just a little bit of a tiny vasculitis, I might not. But in general, also the patients with a lot of vasculitis have a lot of vitritis as well. So I will treat them.
Okay. The IgM, do you use the IgM for diagnosis?
So we see IgM in acquired toxoplasmosis. You know that IgM for toxo is like IgM in all other diseases. It doesn't last very long. So I actually don't get serology in anybody with recurrent disease. But when I see newly acquired disease, I will test IgG and IgM. And I like when the IgM is positive because then I can reassure myself I was correct.
Okay. I think that's about it.
Okay, so let's go on. We're almost there, guys. I'm running out of steam. I don't know if you are as well. So here's a patient referred to me with serpiginous choroidopathy. He's a 62-year-old who's been getting worse despite 2 years of pretty high-dose oral prednisone and methotrexate and cyclosporin. And you can see what looks like classic serpiginous choroidopathy here, but he does have some peripheral lesions. And here you can see the serpiginous, and there's an active lesion here, and there is an active lesion here. When I looked at the patient, he also had interstitial keratitis. You know that serpiginous choroidopathy does not cause inflammation. He also was PPD positive, and we diagnosed him with TB serpiginous-like choroidopathy. This is a 60-year-old woman from Poland with increasing scotomas in both eyes. She had no AC reaction, but she had vitreous cells in both eyes. She had a great history. She had a very convincing history for TB. Her father died in a TB sanatorium. Her quantiferum was positive, and she had CT chest evidence of old granulomatous disease. So this one is an easy diagnosis. You can see here that she actually has an active lesion here, and you can see on the OCT, and she was the first patient I actually saw this, that you can actually see, oh, where's my point? There it is, choroidal lesions. So we call serpiginous choroidopathy, but it's really a disease of the outer retina, RPE, and at most choriocapillaris. They don't get choroidal granulomas. And here you can see she has a choroidal granuloma. This is a very useful way of helping make the diagnosis of TB, serpiginous-like choroidopathy, but also following these patients. Sometimes you can see this before you can see the new lesion clinically, and you can monitor response therapy. So here's a patient with a new lesion. And here is the response to therapy. And now you see a little more extensive overlying retinal disease. So the questions are, how do you tell TB serpiginous from regular choroidopathy? This was a Survey of Ophthalmology article, oh my goodness, almost 10 years ago, with Narsingh Rao. And the features that suggested TB were patients that came from endemic areas, but this is a paper from India. Multifocal lesions, unilateral lesions, a lot of vitreous or AC reactions, and early lesions that were in the macula, as well as response to anti-TB therapy. This was my data, though, on patients with actually confirmed tuberculosis in the eye, so by biopsy or other tissue diagnosis. And so I'm from a non-endemic area, and many of my patients did not have identifiable risk factors. So some did come from endemic areas, some had known TB contacts. We had a nurse, we had someone who worked as a prison guard, but we also had middle school teachers in the city of Chicago. So patients without known risk factors. Most patients had bilateral disease. They were often multifocal, as in the paper from India, and they didn't have a lot of inflammation. And the response to anti-TB therapy wasn't great. And then again, we also were able to show the use of EDI. So how do we make the diagnosis? And it's a really tough diagnosis to make, particularly if you live in an endemic area, because 1/3 of the world's population has been exposed to tuberculosis. And we know that TB skin tests, so the PPD and interferon gamma release assays like the quantiferon, don't distinguish between latent or active tuberculosis. So if you live in an endemic area, you have a very high chance of having a patient with positive TB testing. Overall, 1/3 of the world's population is PPD positive. So most patients with uveitis and positive TB testing still don't have TB as a cause of their uveitis. Then on the flip side, we can see TB uveitis in patients without evidence of systemic TB. So we can see patients with TB uveitis with a normal CT chest. We know that 20% of tuberculosis is extrapulmonary, and half of that is purely extrapulmonary. So there will be no findings on CT chest. You know that Pott's disease with TB in the spine will have no lesions or may have no lesions on CT imaging. In fact, on looking at data of patients with tuberculosis, pulmonary TB is actually negatively associated with tuberculosis in the eye, and TB in the eye is really positively associated only with TB lymphadenopathy. And this is looking at patients with known tuberculosis. Then what about making a tissue diagnosis? Well, PCR is great for herpes. So we have really good testing and we have a really high number of organisms. But if we have tuberculosis in the eye, this is really a paucibacillary infection. So where we might have 9 million copies in the aqueous of a patient with ARN, in a patient with TB, there may only be 500 copies in the entire eye. So the tissue diagnosis is really difficult. And then we also can't look at response to TB therapy because studies, including from the Armed Forces Institute of Pathology, where we had biopsy or histologically proven tuberculosis, therapy was only effective in 40 to 70% of published cases. So we can't look at just a PPD, we can't look at chest imaging, we can't look at response to therapy, so what do? Well, then there's something else that's even more scary, and this is the flip side of it, and I'm gonna ask you to hang on for 1 second. Can you be quiet in there, because I can't talk, thank you. Sorry guys. So this was a study that Amod Gupta did in India, and this was really scary to me. PCR could be positive on ocular fluid on patients without TB uveitis. So he looked at patients with latent TB, so patients with a positive PPD who were undergoing surgery for rhegmatogenous retinal detachment. They had no uveitis at all. And of the 16 patients that he tested, 6 had positive PCR for Mycobacterium tuberculosis in the subretinal fluid. So these aren't patients with uveitis. So we can't even say that if they have a positive test in the eye, they have TB in the eye, because TB can be sequestered in the RPE cells in latent TB. So TB testing isn't enough, chest imaging isn't enough, clinical exam isn't enough, biopsy isn't enough, response to therapy isn't enough. We really don't have a great way of diagnosing TB uveitis or deciding which patients with uveitis have TB. Then once we decide they have TB, how do we know how much of the clinical picture is due to inflammation rather than direct infection? So if a patient is getting worse, do we need to increase anti-TB therapy? Do we need to increase immunomodulatory therapy? Do we need to do both? So in some cases, I think it's more obvious. This is a patient with TB scleritis with large areas of necrosis in the sclera. These, I think, are active infection. This is a patient with TB. These are large lesions in the iris. These are active infection. Here is a huge granuloma. This, I think, is direct infection with a superimposed inflammatory response, but we still know there's active organism. But if we have a patient who only has vasculitis or a patient who has a pterygium, this can be just an immune response rather than direct tissue invasion. So I don't really have a good answer as to how we manage these patients. But despite all these caveats, we really need to work up all patients with granulomatous uveitis or serpiginous choroiditis for tuberculosis, and patients with a positive TB test and eye disease that is consistent with TB should receive systemic therapy. We typically use RIPE for 2 to 4 months, followed by 2-drug therapy for an entire year. Any questions about TB before I go on? I have to catch my breath anyways.
Someone was asking if they can't see the fundus. It's too, inflammation is hindering the view. Would you start with a cocktail protocol to start with to get some clue of what's the infection is?
Yeah, so that's the $1 million question. So the easy thing is if you can't see the fundus, you can easily start treating for acute retinal necrosis and for toxoplasmosis. And that's very easy. You can put the patient on Bactrim or azithromycin and valganciclovir. The problem is if you can't see the fundus and you think it's tuberculosis, because this therapy is much more toxic and much more difficult. So I would consider a more aggressive looking, I can't even speak English, sorry, I'm so tired now. If you think that it's tuberculosis, ultrasound is very helpful. We can often see granulomas in the choroid then, but certainly in somebody with uveitis and no view of the fundus, I would treat or toxoplasmosis and acute retinal necrosis and do an AC tap for PCR for those organisms.
Okay, lovely. You want to go on with whatever you want?
Yep. Yep. Before I run out of steam completely.
All
okay.
All right.
So I only have a couple more diagnoses to cover, I promise. So this is a patient who was referred to the United States from Mexico, supposedly for a pituitary microadenoma. He's a 36-year-old male with balance issues and decreased vision. And he has this classic picture here. You can see that the retina doesn't look normal here. You can see this little line. And here you see much more easily delineated the amount of retinal involvement. And then here is his OCT. You can see that there's disruption of the ellipsoid, little excrescences. This is really a classic picture of syphilitic placoid retinitis. This is syphilis. Clinical diagnosis we made of syphilis. Workup, specific syphilis testing was positive. The RPR was also positive. The lumbar puncture was positive for VDRL. Whenever we see syphilis, we test for HIV. He was HIV negative, and he was treated with IV penicillin. And here you can see that after IV penicillin, he gets resolution here with reconstitution of the ellipsoid. His vision comes back to 20/20, and his pituitary microadenoma goes back to being irrelevant, and he goes back to Mexico. So this is a patient who was referred to me with a diagnosis of AMPI. He's a 26-year-old male who's been diagnosed with AMPI because he has a characteristic fluorescein angiography with early blockage and late staining. His complaint is decreased vision in both eyes. He is healthy and takes no medications. So this is the classic picture. You can see that there's this ground glass infiltrate of the retina in both eyes with these little precipitates or excrescences on the retina. And this is really, in my opinion, a pathognomonic clinical picture for syphilitic retinitis. So we made a clinical diagnosis of syphilitic retinitis. We work him up. FTABS is positive. RPR was positive to as high as my lab tests, which is 1 in 1,024. His lumbar puncture was positive. And in fact, he was HIV positive. He did not know. And his CD4 count was 380. And there he is after IV penicillin with resolution of the retinitis. So I don't have his fluorescein. This is another patient's fluorescein, but this is a patient with syphilitic placoid with a fluorescein angiography showing you early blockage and late staining. So where early blockage and late staining is characteristic for AMPI, it's not pathognomonic. Tuberculosis may do the same thing, and syphilis very commonly does the same thing. So please, even if something looks like AMPI, check for syphilis, and early blockage and late staining is not pathognomonic. So here's a patient who was referred to me a zillion years ago for acute retinal necrosis. He's 42 years old. He's had floaters in his left eye for 6 weeks. Vision is 20/20. His right eye is normal. His left eye has 1+ anterior chamber cells. He has no past medical history, takes no medication. He is a man who has sex with men, no IV drugs, and as far as he knows, he is HIV negative. So here's a picture of his retina, and you can see that this isn't acute retinal necrosis because there's no necrosis. There's this ground glass infiltrate in a triangular pattern. And I don't know why, but this triangular pattern is actually pretty common. So we see an infiltrate rather than necrosis. So when we see this again, we think of syphilis. So I diagnosed him as probable syphilis just based on the clinical exam. Again, FTA was positive. The RPR was positive to as high as my lab tested. His LP had negative VDRL, but and normal protein. So the lumbar puncture was normal. He was also HIV positive and actually met the criteria for AIDS with a CD4 count of under 200. So we diagnosed him with syphilitic retinitis and AIDS. He was treated with IV penicillin and highly active antiretroviral therapy with complete resolution of his retinitis. Here's another patient referred with a diagnosis of optic neuritis. So he's a 30-year-old male. He has an unremarkable past medical history. He takes no medications. He is a man who has sex with men. Again, no IV drugs, and again, thinks that he is HIV negative. He has a normal slit lamp exam, except for 2+ anterior vitreous cells in the right eye, and he has a swollen optic nerve. There is nothing about this optic nerve that looks like syphilis or anything else. It's a swollen optic nerve, and in the periphery, he had what to me really looked like extramacular drusen. But he had a rash on his face and his trunk and his limbs for 2 months. He was seen by multiple dermatologists and treated with every steroid cream known to man. And here's a picture of his rash. So he has a rash on his entire body, but not on his palms and his soles. Syphilis is classically on the palms and the soles, but it doesn't have to be. So this is a guy who had months and months and months of a rash, saw about 6 dermatologists, many in the university, never got a biopsy and never got systemic testing for syphilis. This is syphilis. So we made a clinical diagnosis of secondary syphilis. His RPR was positive, his FTABS was positive, and he was also HIV positive, which he hadn't known about. His lumbar puncture had no syphilis serology that was positive, but there was increased protein, which we can see in both syphilis and HIV. So his final diagnosis was secondary syphilis, syphilitic posterior uveitis with optic neuritis, and actually those choroidal lesions, and I'm sorry I don't have a picture, those choroidal lesions completely went away. So they weren't macular drusen, they were little tiny choroidal or subretinal lesions from syphilis. And we treated him with IV penicillin and heart, and he got completely better. Here's another patient referred with floaters. This is an almost 70-year-old guy, 6 weeks history of floaters, his past medical history, as with most people that are in their 60s or 70s, is positive for diabetes and hypertension. He denies homosexual contacts, denies IV drug use, has no high-risk behaviors. His exam of his right eye is normal. His left eye has 1+ anterior chamber cells. He has vitreous haze. He has vitreous precipitates, posterior vitreous precipitates. So I am sure I'm going to look at and see toxoplasmosis. I'm literally 100% sure. But I look in and I can't find any toxoplasmosis. All I find is this little subtle area of infiltrate. That's not what toxo looks like. So I don't know what this guy has. He's 67 years old. He has no risk factors, but I work up every single patient for syphilis. It doesn't matter if they're 100 years old. It doesn't matter if it's my best friend's grandmother. It doesn't matter if someone tells me they're a virgin. Everybody gets tested for syphilis. So his workup, his ACE was normal. His lysozyme was extraordinarily elevated. And in fact, the highest lysozymes I've seen in my life are in patients with syphilis. His RPR was elevated, his FTA was positive, and he actually was HIV positive as well, which tells you not to believe everybody's history. We treated him with intravenous penicillin and highly active antiretroviral therapy with complete resolution of his retinitis and his vitritis. Here's another optic neuritis. This is the 32-year-old male referred for bilateral uveitis and optic neuritis. He comes with his wife and 2 children. He has no risk factors. His visual acuity is decreased in both eyes. He has vitritis in both eyes, and he has very swollen discs in both eyes with no retinitis. But here's an examination of his hands, and there's his feet. This is classic syphilis. So despite the fact that he says he has no risk factors, this is secondary syphilis. And we worked him up. His FTA was positive. His RPR was positive. His lumbar puncture was positive for syphilis, and he was also HIV positive with AIDS. So we diagnosed him with syphilitic uveitis, neurosyphilis, and AIDS. He was treated with IV penicillin and highly active antiretroviral therapy. His disc edema as vasculitis got better, but he was eventually lost to follow-up. So suspect syphilis in everybody. This is a picture that is pretty classic for syphilis. This is a picture that I think is pathognomonic for syphilis, but this is just disc edema. So anybody with inflammation in the eye, retinitis, choroiditis, retinal vasculitis, optic neuritis, any inflammation needs to be tested for syphilis. So syphilis can occur at any, syphilitic uveitis can occur at any stage of syphilis. It's not an AIDS-defining illness, but as you could see from the patients that I showed you, it may be the first presentation of AIDS. And in fact, when I looked at my patients with syphilitic retinitis, almost all of them also had HIV. So how do we test the patients? We can do non-treponemal tests and treponemal tests, and I do both. So the non-treponemal test may become negative with treatment. This is RPR and VDRL, and there's a lot of treponemal tests, and in theory at least, these are positive for life. This is FTABS, MHATP, TPPA, TPHA, or what we do now, which is the treponemal enzyme immunoassay for IgG and IgM. When I trained, we had huge fights with the labs because we always wanted an FTA and an RPR, and the labs always told us, no, you don't need to do an RPR if the FTA is negative. But more than a decade ago, the CDC in the United States says you need to do specific treponemal tests first. If that's positive, you reflex to a non-treponemal test. You can also do PCR. PCR has been shown to be positive in aqueous and vitreous in patients with syphilitic uveitis, but I haven't done it because their blood tests are positive and they come back in 24 hours. So I haven't done this, but it is possible in cases that are questionable. So everybody with uveitis gets worked up for syphilis. It doesn't matter if it's your best friend's grandfather or your best friend's grandmother. It doesn't matter if the person tells you that they are the most religious person in the world and they've never had sex. Everybody gets tested for syphilis, treponemal tests and non-treponemal tests. If the serologic testing is positive, it's suggested that they get a lumbar puncture as well. We need to do HIV testing. We treat patients with 14-day IV penicillin as the gold standard. And I think this is really interesting in the age of multi-drug resistant staph and strep that are probably our first recorded disease is sensitive to our first antibiotic. So I'm just going to go show you a couple of pictures of a few miscellaneous diagnoses because this has been almost 90 minutes. Toxoplasmosis, Toxoplasmosis canis tends to be unilateral, tends to present as endophthalmitis in young children, isolated granuloma in older children or adults, and this is not a visceral larva migrans. There doesn't tend to be systemic eosinophilia. So these are two adult males with Toxoplasmosis, and you can see the extent of subretinal fibrosis and pre-retinal fibrosis. Presumably, this is where there was an active granuloma in the past, and you can see a lot of pigmentary change around it, subretinal and pre-retinal fibrosis. This is a patient who was referred to my retina colleague, and you can see this fold in the retina, but if you follow it out, there's a granuloma in the periphery. And in fact, Toxoplasmosis is in the differential of unilateral pars planitis. You know that pars planitis is typically bilateral. It can be very asymmetric, but if you see purely unilateral pars planitis, think about Toxoplasmosis. And this is actually the only kid I've ever seen with Toxoplasmosis endophthalmitis. There was a granuloma here. Oh, where's my pointer? There's a granuloma here. There was a stalk, and there was this giant thing here that looked like a snowbank, but where it didn't belong. And this turned out to be Toxoplasmosis. So the parasite is presumed to be dead when we see the patient, whether it's cicatricial disease or there's vitritis. So we don't tend to treat with thiobendazole or albendazole, although you can get therapeutic intraocular levels. And we use corticosteroids here to reduce inflammation. This is one of the few cases where we have infectious disease that we treat primarily with anti-inflammatory therapy. This is a beautiful case from Ramana Murthy in Indiana. This is a 9-year-old girl, 2200 vision because of a Toxoplasmosis granuloma with a tractional detachment. And here she is after vitrectomy, removal of the granuloma, and she goes back to 2020. Diffuse unilateral subacute neuroretinitis. This is a nematode. A lot of different nematodes have been reported. And the patients tend to present with unilateral disease. Bilateral disease has been reported, but it's really not common. They get these successive crops of lesions. They're gray or yellow white. They're deep retina, outer retina, and RPE. The lesions fade over time, and then you get new crops of lesions. Discedema is common. Mild vitritis is common. And you can see the worm, if you're lucky, often next to the lesion. So you look for where there's the whitest lesions and look for the worm. And here you can see, this is the color photo, and I didn't know what this patient had. The patient was referred with some weird diagnosis of unilateral AMPI. I missed the worm clinically, but I thought about AMPI. I thought about Duzen. Here you go. You can see the worm under the vessel here. By the time we get to the red free, and thankfully I was in the room, you can see that the worm is now no longer under the vessel. So we didn't do the fluorescein angiogram, rush the patient to the laser because we saw the worm, and we shoot to kill. We don't try to surround it, we don't try to stun it, crank up the laser, shoot to kill. If you can't find the worm but you really suspect it, you can add albendazole. Sometimes that'll slow down the worm enough that you can find it, and it may kill the worm as well. Bartonella, we're always taught that Bartonella is most commonly presenting as neuroretinitis. In fact, multifocal retinochoroiditis is much more common than neuroretinitis. So this is the classic lesion of multifocal retinitis from Bartonella. This is Bartonella henselae or Quintana. And treatment is very controversial because patients can get better on their own. I actually do tend to offer therapy, and we have a lot of options: azithromycin, doxy, cipro, erythromycin. There's a lot of organisms. So I think I'm done talking to you about particular diseases. I'm going to summarize with my take-home or stay-home points. Every patient with uveitis and scleritis needs a good fundus exam. All of these patients presented with pain, redness, and photophobia. This necrotizing herpetic retinitis presented with pain, redness, and photophobia. This toxoplasmosis patient was treated for weeks as anterior uveitis, and this syphilitic retinitis patient also had AC cells. Assume that any patient in whom you see retinitis has infectious disease until proven otherwise. If you aren't sure, treat as infectious. Always work up for infection. We think about acute retinal necrosis, which we can diagnose from AC tap. We think about toxoplasmosis, clinical diagnosis, or AC tap, very helpful. Syphilis, which we diagnose by serology. Tuberculosis, which I talked to you about, is horrible to diagnose. And finally, last slide, guys, you survived. Not all uveitis is treated with steroids. Thank you.
Thank you very much for this lovely presentation. It was very informative and very beneficial. I myself learned a lot out of it, and I can see from the comments everybody was excited about it. Thank you very much. And do you wanna take a couple of questions?
Sure. If there's a couple more questions.
Okay. Let's see if anybody would like to raise his hand. And let's take, we have two raising their hands. We'll take the two questions and then we'll wrap up.
Okay, great, thanks.
Okay. Abdul Jawad, Dr. Abdul Jawad.
Yes, hi, Dr. Weil. Thank you again for organizing these lovely talks. And thanks, Dr. Debra, for very nice, well-presented talk about infectious retinitis. My question is basically, I am actually Dr. Gashut from Libya, but working in the UK at the moment. If you have a patient who would have very dense vitritis, and you can't make actually any hint regarding the cause, we know that investigation will take a few days. Would you have any protocol to cover, as at least, toxo and ARN
Yeah,
sort of
absolutely.
infection? Do you have any protocol to start with?
So in the UK, you could get valacyclovir. I would start with 2 grams TID. I would also start treating for toxoplasmosis while you're waiting for your workup. So you can use topical steroids for the AC reaction. That's not going to do anything bad. Azithromycin or Bactrim or something for toxoplasmosis. Valacyclovir for herpes, and send off testing from aqueous if you can do it, if not from vitreous, for PCR for everything you're looking for, including if there's dense vitritis. You can think about bacterial endophthalmitis, so you can do eubacterial and panfungal primers on PCR and send off syphilis serology, and then either quantiferon gold or PPD, and then whatever other workup like sarcoidosis and whatever else.
Okay, we have Dr. Ruwaida Al-Rufi. Dr. Ruwaida. Okay, she's not with us. Dr. Dina Baddar.
Hi, Dina.
Assalamu alaikum.
Ahlan, ازيك يا دينا?
Just I want to ask about.
Dina, you keep muting yourself.
So while we're waiting for Dina to unmute herself, there's a question, how much sample is enough for aqueous PCR? We always fight with our labs. They seem to want 6 cups of fluid out of the eye. I usually try to take out 0.1 cc, and that's enough for PCR for all the herpes viruses and toxoplasmosis. You can do it on less than that, but you get between 0.1 and 0.3 cc's. I do the aqueous tap at the slit lamp. It's really helpful to have another pair of hands with you. I don't like to do it with the technique that people do without the plunger, because I'm worried about losing my specimen when I put the plunger back. So I have a 1 cc syringe, a 25 gauge needle. Work the plunger first so you make sure that there's not like a vacuum. Go in at the slit lamp and have somebody pull back, and you can get between 0.1 and 0.3 cc's. If the patient's pseudophakic, it's really easy, but even if they're phakic, you can flatten the anterior chamber and it'll reform.
Okay. Dr. Adina Budar, are you going to ask your question?
Yeah, yes, I have my question. Hi, Dr. Goldstein. Quick question.
Yeah.
How do you approach a case of TB sarcoid? So I recently had a patient with a positive PPD and a biopsy-proven sarcoidosis. How would you approach that patient?
So, you know, it's a really tough differential between the two. And the most important thing is that the biopsy be looked at very carefully for acid-fast organisms. Because we know that we don't see organisms on every single slide. Often we'll get a patient with a biopsy that says sarcoid because the granulomas are non-caseating. But in fact, in TB, not every granuloma caseates. So if the patient has good biopsy and they're really convinced that this is not tuberculosis, you can go ahead and treat for sarcoidosis. Even in tuberculosis, you can get away with a few weeks of steroids first. In India, sometimes they use 2 weeks of 6-diprednisone before starting TB therapy. So this is not like acute retinal necrosis where the disease is going to progress very quickly. So if you're in Egypt and the patient has a positive PPD, that's not surprising. So as long as the biopsy is really well examined for tuberculosis, I would actually try to treat for sarcoid. If they don't do well, then I would institute TB therapy.
All right. Do you still have energy?
A little bit.
Okay, I will get one last question. Dr. Ferial Sayed. Dr. Ferial. Okay. Dr. Abir Khattab. Dr. Abir.
Yes. I don't know, good afternoon or good night. Dr. Debra, may I ask you, did you notice any correlation between the current COVID-19 and increased uveitis?
So I really haven't. That's a great question. But I haven't seen a lot of new uveitis. One interesting thing is that I'm seeing more flares of my B27 uveitis patients, and I don't know if that's just stress or what that is. But certainly, otherwise, I haven't seen any correlation. That having been said, half my patients are too scared to come to the office, so I could be missing things, but I haven't. I saw one other question on the chat. I was asked, in an endemic area, do you prefer PPD or quantiferon? The advantage of quantiferon is in patients who've received a BCG, because the PPD is looking at can be made positive by the BCG. Now, the PPD should fade over time, even in somebody with a BCG, but it makes it a little harder to read. Quantiferon is a different antigen, so I prefer that in patients who've had a BCG, which is more common in endemic areas. So that was just one of the chat questions I was answering.
So I guess this is a wrap up. And
okay.
I'm sorry that we kept you for a long time.
No, this was really fun. Thank you.
Thank you
this was
very
really
much.
fun.
Thank you
I hope
very
it was
much
helpful.
to everybody who stayed with us. And we are definitely very honored to have had you with us today. And thank you very much.
It was my pleasure. Thank you so much.
I'd like to remind everybody that on Wednesday, we have Dr. Heba Mitwalli's third part of the strabismus course. And on Friday, we have the cataract surgery rumble with Dr. Ahmed Assaf and Dr. Uday Devgan. and me, myself, we're going to be discussing cataract surgery, different topics, as you can see. So see you on Wednesday and see you on Friday. And thank you again, Dr. Debra. Your presentation was more than amazing.
Thank you. It was my pleasure.
Thank you.
Good night, everybody.
Good night, everybody, and see you on Wednesday.